Hi, everyone. Thanks so much for joining the second webinar today from Excite. We're really excited about the panel that we have to talk about a really interesting and sometimes confusing issue that touches us family physicians and healthcare providers in ways that we don't even realize is affecting patient care and our workflows. So it's really who is in charge of our EMR data. There's a lot of tension in terms of doctors having to be the custodians of data, but patients sort of own their data, and then how the data flows through the system. And there's different technical systems that underpin how data flows from one place to another. And there are a lot of policy decisions that are made that impact how facilitated this occurs, and how sometimes it ends up being an opportunity that we miss in terms of improving patient care by having a shared understanding of a patient persona between different providers. So we're really excited to delve deep into this. Next slide. So before we get started, first we want to acknowledge the land that we are on. So we're based here in Toronto. So we wish to acknowledge this land on which we gather upon today. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Okay, so I'll introduce myself first. I'll be your moderator today. I'm a family physician based at Toronto Western Family Health Team. I'm also a clinician investigator, and my research focuses on the use of primary care EMR data and digital interventions for primary care. And so I think I can position some of my questions with that lens for the panel today. We have different perspectives on this issue joining us, which is great. So we have Dr. Alison Paprasa, who will introduce herself, bring sort of the system lens, a bit of the technical and policy lens. Ms. Christine Sham bringing definitely the policy and government and ministry lens, and Dr. Kareem Khashoggi, who is a physician, but also an EMR data expert. So really a robust, different set of perspectives on today's issue. Next slide. So in terms of the disclosure of financial support, so this series has received in-kind support from the Department of Family Community Medicine, University of Toronto, in the form of administrative and promotional support. The Scientific Planning Committee has selected the topics, moderators, and panelists for the series, and the committee included 5 family physicians with knowledge in this area: Dr. Andrew Pinto, Catherine G., Cheryl Spidoff, O'Neill Bhattacharya, and myself. And the conflicts of interest are displayed on the next slide. All right, so for myself, I'm primarily a researcher. I have a invention that we are in a pre-commercial stage of commercializing, and that's in a startup called Mutual Health Solution. And that's around the digital scribe technology, which touches a bit on this area, but really is very separate. I have no other conflicts of interest to disclose. And in terms of Kareem, if you can just speak a little bit to your conflicts of interest today.
Thanks, Noah. Sorry I'm late. Yes, where there's no conflict, there are no interest. So I have lots of conflicts of interest. I'm on contract with the University of Toronto. I'm an assistant professor and program director for the Master of Health Informatics program. I'm also a consultant and owner of InfoClan. I have recently consulted on an app for a company that was developing it for a pharma company. I'm also currently consulting with McMaster University to develop a prescription parser for automating their prescription exam marking. So, but where there's conflicts, there's also confluences of interest. That's me.
Great. Okay, next slide. Alison, do you want to just...
Sure. So I'm Alison Paprisa. I am assistant professor status at IHPME with a cross appointment to laboratory medicine and pathobiology in the Faculty of Medicine. And I also work at Health Data Research Network Canada and ICS. I have no conflicts to declare. I am a member on multiple research teams with Tri-Council and other funding. I occasionally receive honorariums, but none from private sector organizations. But I will disclose completely separate from this, I'm principal of a small consultancy, and through that I provide facilitation and project management services to many universities and also government agencies, but not related to this topic in any way.
And finally, Christine. Oh, I think you're on mute.
Hi. It always has to happen at least once during a session, and it was me. Thank you. I'm the Director of Information Management Strategy and Policy in the Ministry of Health, and I'm also adjunct at the Della Lana School of Public Health. And I have no conflicts to declare. I'm just a boring bureaucrat.
Okay, so we're hoping today will be a very sort of interesting, dynamic, interactive panel discussion. So yes, the panelists will discuss amongst themselves, but we'd really appreciate if some of you could put forward some questions you may be having about this issue, or just some comments, and hopefully we'll spur some discussion amongst everybody. And the way to do that is you can use the Q&A box at the bottom of your screen. And you can press thumbs up for people for other questions you're interested in, upvoting, and chat box for just connecting with us. Those are your standard Zoom panel tools. All right, so Kareem, if you could start off and introduce yourself, and then go through some of just a gentle presentation on this area from your perspective.
Great. Thank you so much, Noah, for having me. And it's a topic that is close to my heart and has been for a long time. So I appreciate being asked to be here. Basically, I trained as a family doc, practiced family medicine for about 20 years. I also have been doing health informatics consulting for the last 25 years or so. I stopped practicing medicine about 7-8 years ago now to focus on health informatics. Probably one of the biggest projects I worked on was SIPSIN. I designed the data extraction processes for extracting data from multiple electronic medical records, de-identifying, cleaning up the data, and bringing it into a central repository for research and surveillance. That system is now up to about 2,000 physicians and has probably close to 2 million patients in the database. So it's quite a fantastic asset for research in family medicine. So I will say that, one of the big questions and that creates kind of the greatest controversy when it comes to EMR data is that who owns the data? And I think the Supreme Court has been very clear about that, that the patient owns the data, and but it's ownership is a very interesting concept when you deal with something digital. See, when I own land, and nobody else can own it because I own it. But with digital assets, you can own it, and I can own it, and we can all have a copy of it, and we can all own it. And that becomes a very interesting dilemma, because the concept of ownership doesn't make sense the way we traditionally think of ownership. And so, but the courts have said that the patient owns the data, but unfortunately, legislatively, the patient doesn't really own the data. And so this concept of ownership has not been solidified in the legislation. And so, patients are left in somewhat of a limbo around their ownership of data. Now, the same Supreme Court decision, McInerney and McDonald, also established that the physician is a custodian of the data and owns the copy that they created. And the custodianship has been enshrined in legislation. And so PHIPAA does say that physicians and other regulated healthcare professionals are health information custodians. And so that concept is there in the literature, in the legislation, sorry. Now, from my reading of the legislation, the PHIPAA legislation, basically the physician is not really accountable to anyone other than themselves. And when it comes to that data, and but if there's a breach, then they are accountable to the patient. And more recently, they do have to report it to the Information Privacy Commissioner of Canada, of Ontario, of the province. But that's not really an accountability. It's more that it's a regulated requirement that you report it, and it's more for investigation and forensic purposes. Of course, you might get fined for doing that, but that's not the real purpose of that kind of reporting mechanism. Now, the legislation does have several rights that patients have to their data. They have the right to access their data. They have the right to correct their data. But the access is 30 days, according to PHIPAA, which is really not a very timely access. And so that's fine if you're going to be hospitalized, and you want your records so that you can take it to the hospital, but it's not really great for if you want to look after yourself and you need access to the information for your own personal use. That's not very convenient. The US has actually moved to a 2-day or 48-hour turnaround on having access to their data. And that's been around for almost 10 years now. And I'm hoping that here in Canada, we will move to the same turnaround standard, so that patients who own their data will actually have unfettered access. And hopefully the legislation will also provide some guidance around the aggregation of that data, so that patients have access to aggregate, the data that comes from all the different organizations that they might have interacted with, and have all of that data in one place, rather than having it fragmented in all the different places that they might have seen, so that they can have a central access to all their data. But I think that's kind of my key main messages around who owns the data.
Wonderful introduction to the issue, Kareem. Thank you so much. It's legal is not something that we think about actively in our practice, so this is just important that we become aware of these sort of things. Maybe just touch on one small question just before we move on to the next presentation. It's something that we think about. All the different custodians charge many of the time they charge a fee for the patient to get access to that data. Is that born out of some legislation, or where does that sort of customary practice come from?
Well, I mean, I think, in the old days, making the records accessible was costly, because you had to go and find it. You had to make photocopies of it. Photocopying is expensive. The time to make the photocopies was expensive. The time to retrieve it and refile that was expensive. And so, if doctors were asked to give all of that for free, everybody would ask for their records, and all of a sudden, that's all you'd be doing. And that was the concern. And so the legislation doesn't stop you from charging. It just says that you can't charge an exorbitant fee, you can't make a profit out of it, but you can charge to cover your costs. And so typically the charge was to cover costs. And, photocopying is expensive because, you know, even though the paper piece of paper may only cost 5 cents, the time of the individual to do that may actually cost, you know, 10 cents or 15 cents or 20 cents. And so we have to include the labor. And of course, you know, anytime you hire somebody, there's an overhead cost to having that person working for you, which is an equivalent to their entire salary as well. So, you know, costs actually are quite high for doing things. Now, you know, in the electronic world, I think those costs are becoming almost negligible. And I think, you know, we've traditionally asked to be paid for making records accessible. Now, of course, there's always an overhead of technology. You know, computers don't come for free, and you know, maintaining the access to records is, you know, is a support cost, and so that should be covered. But I think, you know, we need to think about making that infrastructure cost, which these days will be very, very low, but still, you know, still real. And if you want to make it accessible to all your 2,000 patients, then there's going to be a significant cost. And I think that needs to be recouped in some way or another.
Great. Yeah, that's really enlightening about the history of that, as well as how it should be currently implemented. Makes sense a lot. Okay, great. Let's move on to Allison's presentation.
Hi, folks. I think I'm going to follow Kareem's lead and have sort of one central word for my few slides, and that's going to be trust. It's going to be how your patients perceive the environment in which their data is managed, and how trust directly affects the kinds of things we can do with data and what we can learn from it. And so you've got a few headlines showing here on the screen, including one, I think it was about 1.5 years ago, about TELUS, medical record software companies are selling your health data. But these are headlines from around the world. And if I look today, I'd find some new ones. We're overall working in a very low trust environment when it comes to how people feel about their data. And the things, no matter how you know, secure and appropriate your own processes are, people are affected by what they read in the headlines, and generally it erodes trust. And if we can build and maintain that trust, we're going to be able to do many more things. One of the first, if you just hit the animation there, whoever's working the slides, one of the first times this really came to my attention was through something called care.data. And this is a real cautionary tale, and there are others, but literally this is the NHS in the UK, millions of dollars into a massive data sharing scheme or plan that included, you know, flyers that went to people's houses, and they thought they had it covered. They thought they were in that space where people would clearly see the public benefit. But there was huge outcry, and if we hit the last animation, to the point that it was canceled. Millions of dollars worth of investment in data sharing was canceled, and it was generally understood to be lack of social license. In other words, even though everything was completely legal and even though communication happened, the public just did not support the kinds of data sharing that the government was, or the NHS rather, was working on. And in some ways, the UK is going through this again right now. There was a big plan, you may know, to have, you know, you had to opt out within 6 weeks, or your data were going to be used in a large de-identified data set. There was huge outcry all the way up to Parliament. It's been delayed twice now that I know of. We'll see where it goes. So this literally can be headline news. So if we go to the next slide, this is where I've really come to understand this idea of social license, which is different than what's legal, so different than what Kareem talked about. And when I first started learning about it, I thought, oh, I get it. Like, there's a bunch of stuff that's legal, but only a subset of those things are actually within social license. But over time, I'm seeing it more as like this figure on the right-hand side, where there are things that people actually expect are happening with their data that in some cases we are legally prohibited from doing, or at least legally prohibited without express consent. And of course, we don't get express consent for all the kinds of things that we do. And I'll add to this that there's also evidence that this can be jurisdiction specific. So for example, in Denmark, where they have a long history of use of population-wide databases, it's okay for someone to be contacted by a researcher directly saying, you know, would you like to be part of our diabetes study? But in Scotland, that won't fly. Really, you would only be contacted by someone who you would expect to have some access to your record, like a nurse or someone from your doctor's office. So variation, and we can't anticipate exactly what that variation is going to be. So if we move to the next slide, Sorry, next slide. That's just, and apologies for the cacophony here, but I think in some ways it might be good to have it because, you know, people have views on this. These are selected findings from over 100 people that have been involved in focus groups on uses of health data, secondary uses of health data, including using health data for AI. And our studies show, these are all Ontario focus groups, some in Toronto and Mississauga, others in the North, Thunder Bay and Sudbury, that are they consistent with what we hear internationally, that there's general but conditional support for widespread data use. People see data as an asset, they want it to be used, but the current situation where you might have some long terms and conditions or privacy policy that you click I accept to, they see that as them almost being fooled into their data being used. And they do, of course, worry when there's commercial involvement because they find it hard to imagine that the public benefit will be there. They also worry, they hear about hackings, including of very sophisticated organizations like CRA and big banks, and they wonder that no matter what we do, there's going to be some risk of a privacy breach, no matter how careful we are. So I'm going to close with this slide and say that it's just the first step, and I'm really interested in having dialogue with the participants here at Health Data Research Network in Canada and ICS. We're very much thinking about, well, knowing this now, knowing this general conditional support, you know, what are the things we can be doing? And we have a number of projects focused on things like plain language to build transparency and trust. And I'll put right into the chat something that I know Christine knows very well. Work that we've done on essential requirements for establishing and operating data trusts, really trying to get to the heart of what matters when we're looking at trustworthy and responsible uses of data. And I'll stop my slides there and look forward to questions now from you, Noah, and later from everyone participating.
Oh, that's so interesting, Alison. Thank you. Yeah, this is such important work because you know, in terms of what just in my day-to-day as a family physician, patients are sort of unaware as to where their data is flowing to. And a lot of the times they're frustrated that the data that where they expected it to go isn't there. So I guess some of the questions about like, what would be the optimal sort of consenting mechanism where it's not too onerous on the patient, but you know, there's implied consent. How are we going to work this out in a way that is patient-centered and you know enables a streamlined workflow?
Okay, so I'll actually start with non-consented data because I feel like that's a risk for all of us, that we're talking so much about consent and things like GDPR that people will just assume, oh, my data won't be used without my consent. And that is not true. For certain public health things, for topics like the opioid epidemic, we do use data without consent. So foremost, I think we need to be really transparent that in selected cases, we will use data without consent. And in those cases, we really have to have deep public involvement in the decisions and policies we set up to make sure that we have social license. When it comes to consent, I'll tell you about a project that we're working on right now. It's an international one out of Health Data Research Network Canada. And I just want to compliment the team members there, including 8 members of the public and people that work in inclusive design, you know, separate from health altogether. Because what they've really initially, we thought we would work with members of the public to develop what was notionally maybe a 1 or 2 screen data notice that got at what was most important to people when it comes to their data. And we can think of this maybe as comparable to like Creative Commons license marks that we put on our presentation. You'd have an icon or you'd have some very simple information with detail behind it. We're not claiming that icon is sufficient in itself, but if people are looking for a high level understanding, we give them that information with the detail if they want it. And initially we thought we'd maybe, you know, use a Delphi process and consensus building to get to 1 screen. But one of the things that our team members have really pushed on is, look, one size fits one. And I think that's so relevant when we consider, for example, things like the discussion about race and ethnicity data right now, right? So instead, we've pivoted the project and we're no longer going to create a single screen, but what we are going to do is have generative dialogue to have a list of, I say notionally, 60 bullet points that some people might care about. And then through iterations, each and every person involved is going to create their own data notice. And then we're going to talk about some of the differences and similarities across them. So I think that kind of thing, where we're not second guessing the information people want, and we're also allowing that different people may care about different things. Some people may care about the number of people that access data. Some people may care how long it's held. Some people are really sensitive about private sector involvement. I think we need to work so that we can personalize it. And I'll stop there. It's actually a very interesting field, this idea of like a portable personal privacy policy that goes with you and that your data always respects your personal policy as opposed to the policies of the organizations you work with.
That is so interesting. So future oriented and, you know, patient empowered. I love the concept. Great. All right. So we have our last panelist. So she's going to bring a slightly different perspective. Go ahead, Christine.
Thank you. So if I had to pick one word to kind of encapsulate my presentation, I would focus on the word use. So 20 years ago, a stack of paper with information about you was just that. You couldn't really do much with it. And now we call it your digital footprint that you're leaving behind. But I think that it's far more significant than that. Data about you is you. And we need to look no further than the Cambridge Analytica scandal to know the power that data has in today's society. I actually think we should get away from the question of who owns the data, because I think it leads us down a rabbit hole that is almost impossible to emerge from. I think that data is a mirror, a reflection of reality. So if you think about it from that perspective, asking the question, who owns reality, seems like a nonsensical question to even ask. So from the perspective of data, I think we should be focusing on the beneficial uses of data that serve the public interest and the public good. So my slides just kind of tell a little bit of the history of how we got to where we are today with our data governance models and so on. And the eHealth EHR/digital health strategy is one that has been in existence for about 20 years now or so. And it is what I refer to as provider-oriented architecture. It's really great at digitizing the endpoints in the healthcare system. So most physician offices are now digitized, hospitals, community organizations, and so on. And the electronic health record itself has been great at digitizing entire domains of information like labs, drugs, imaging, and so on. But 20 years on into this strategy, we still have some persistent data sharing islands, and that's still problematic. And we have to ask ourselves if this is still the right strategy to get us to the last mile. And what I would say is that it's the provider-oriented architecture and thinking that has created some of the problems that we have today. And we need to move to something akin to the next slide, which is what I call patient-oriented architecture, where we're putting the patient's interest at the center of every data sharing decision that gets made and thinking about what would benefit and serve them. So if we move to the next slide, this shows what patient-oriented architecture could look like at scale. So the patient has a chart. Every time there is a record that is added to their chart in terms of an encounter that they have with the healthcare system, the patient can then lock up their record and have the consent keys to unlock their record for every subsequent use. So they do have the right to control the subsequent sharing and use of that information. And so conceptually, we're grounding this in thinking about them and their rights to control that information. Now, some people would say that, if you have the patient consenting to every single transaction that happens in the healthcare system, that might not be a feasible model because the system might shut down. And I think that number one, we do need to think very carefully about what kind of consent management regime we would have in place to support and empower the patient. But we also need to think about a second construct or idea that we're exploring at a provincial level, which is that of the Health Data Authority, which is at the bottom of this slide. So in addition to the patient having a set of keys to unlock their record for subsequent uses, the Health Data Authority would also have a second set of keys to unlock the patient's chart for subsequent use. The Data Authority conceptually would not have any independent ability to do what they want with the data. Their authority is grounded in two sources. Number one, either the patient and their consent directives and permissions, or number two, it's grounded in a democratic vehicle, i.e. legislation. So we actually already have this in PHIPA right now. The circle of care model, the assumed implied consent model, is one that does not require explicit / express patient consent every time you share data and information. And this is because we believe that it is in the patient's interest for that model to exist. It certainly makes many things much more streamlined and easy. And patients assume that providers are sharing information for the purposes of their care. So that's an example of a use case. The second one is research, where there are beneficial uses of data for research purposes at scale, and sometimes it's not feasible to obtain express patient consent for using provincial level databases. In those cases, we have rules under PHIPA that also allow researchers to gain access to data without getting express patient consent. So if we could actually go through all the use cases in healthcare like this, to think what are the beneficial uses of data and to understand the conditions and to validate them not only with the healthcare system, but also with the patient around their preferences, concerns, and so on, we might actually get to a much more robust health data ecosystem where there is more sharing to support beneficial uses of data that, again, serve the public interest and good. So what we're talking about potentially is moving to something like the next slide in the future state, which we refer to as the data sphere, where the top layer of this diagram is the data and digital platform that we all know that exists in healthcare today, where many healthcare organizations and providers are already capturing information digitally. The challenge is that information can't be shared easily between these different points of care. And what if we had this data authority construct? So it's just a construct at this point. We don't know, is it a single organization, multiple, is it government, is it agency? There are no answers to that, and that's work that we still have to do this year. But this data authority would essentially be the single source of truth for healthcare, for subsequent uses of healthcare information. It would collect the data once, process it once, and could enable reuse many, many times. So this would be the thing that would oversee the application of all policies that govern the movement and flow of data in the health data ecosystem. What we're talking about is taking some of those local information sharing decisions out of the purview of the individual health information custodian itself, because that's how our system is set up right now. It's provider centric. Not only is our technology provider centric, but even our health policy and privacy legislation is provider centric, in that the custodians are the ones that are making all the decisions about information sharing. And for that privilege, they also have the pleasure of bearing 100% of the risk of those data sharing decisions, even if there is public benefit and interest to do that sharing. And that's really the problem that I think that we have to solve. So what if we elevate that? If we believe that data is a critical to have to support healthcare service delivery and other healthcare system uses, should we not be thinking about administering to this at a provincial level, grounded in rules and principles that reflect the patient's consent, choice, and interests, and also other democratic vehicles like legislation? And that is essentially what the data authority would be meant to reflect and encapsulate. They would then be the data brokers in many ways to enable the subsequent use of data. And so all those icons at the bottom reflect different service pathways and different use cases for data in the healthcare system. So over the last 20 years, we focused almost exclusively on the electronic health record and its use for clinical care. But there are many other beneficial uses of data there. And that's just a smattering of what we know is difficult, if not impossible, to enable today. And what we need to do is to consult with our healthcare system on what it needs, and then to also ask our citizenry and validate with them that these are beneficial use cases that they would agree with. And that's where I want to end this slide, and is the reason why I think that we need to focus on use as opposed to ownership.
Wow, I haven't heard this before. It's so interesting to see the vision that the ministry has, and I actually think it's definitely moving in the right direction, which is what we want to hear from our health ministry folks. I have a couple of small questions, and I guess this will transition us into the larger panel discussion. One is, how does this interrelate with what sort of already has been launched, which is this Ontario Health Data Platform? We heard a little bit about it being used for research purposes, but it never really sort of became in our consciousness. Is this related? Is this a different use case? Maybe you can speak to that.
Good question. So I would say that in this slide, on the bottom left-hand side, you'll see an icon for research/data science. So I would say that the Ontario Health Data Platform is one of those use cases that we realize we need to do a better job of enabling, because it's currently very difficult to get access to data for research purposes. So I'd say that the data platform was certainly a catalyst for doing much broader thinking about how we can not only support research uses of data, but all other beneficial uses of data.
Okay, awesome. And my second question was, actually, the vision is really wonderful, and I think aligns a lot with my personal values as a family physician, and obviously would want to learn more details, but I can imagine the transition from the provider architecture to this, future patient-centered health data authority approach is going to be extremely challenging. So let's say we do get consensus that this is the direction we do want to go in. What timeline are we thinking about before we're at a place where this is, working well for patients as they navigate the healthcare system?
That is a really good question. And what we're talking about is definitely a journey. This is probably a 5 to 10 year journey at a minimum. So we're not talking about trying to rush to get to the end state. I think that there's still a lot of unknowns about the data world. And so we need to proceed in a very thoughtful and consultative way. So this is something that we would have to achieve over time, especially because this does represent a paradigm shift, and not only conceptually, but also physically in terms of the technology, underlying technology, structures and systems. And we can only achieve changes to those over time.
Naturally. Okay. So thanks everyone for their presentations. I think it's a lot to think about, a lot to wrap your head around. One thing that I wanted to put to the to the audience is, just to stimulate a little bit of interactivity, is this bit more of a tension area where I've experienced this in terms of, trying to leverage quality improvement dashboard use cases of my data. So some EMR vendors are limiting access to the public good of EMR data for research and quality improvement, and this is not in our view that in the public's interest. They either falsely state it's technically too complex to extract the data, or impose an exorbitant cost on us providers to enable that extraction. This is a bit of an early kernel of what's going to be discussed in the next webinar panel, next Excite in a couple of weeks. But I just wanted to see what the two questions on this, what the audience thinks. First of all, given this background, how will this likely be addressed by government and professional bodies? So maybe you want to take a minute to respond to how we will sort of enable the public good access to EMR data. I'm not sure I'm able to see any responses on my end. Okay, great. Okay, so I'm happy to see this first response because obviously we have Christine's presentation showed optimism about how the ministry is addressing this. So great. So then the second question is actually built on that. So let's go to the second question. So it's really getting at the difference between what we think will happen, maybe a bit of a realistic perspective versus, what our values are, what we think should happen and try and make happen, right? See if there's a difference between the responses between those two questions. Okay, so pretty similar, but it seems like a few of the participants who moved, who originally said nothing will happen, seem to have moved into the government legislation. Approximately sounds like that's what happened here, which I think sort of shows some difference in the perspectives in our audience members today. So that's great. And yeah, this is exactly the point. I want to kick off a conversation. Maybe our panelists want to speak to this issue first, and then hopefully we'll get some questions from our audience members.
Sure, no. So I don't want to throw a wrench in the poll or anything, but I think the options mix a few different concepts. And so I just want to say a little bit about what I know about this and what I think is the way forward. The UK has a very interesting approach on this right now. They're not treating it as something that requires legislative change. They're like, oh, it's just a little bit of sloppy procurement, really, is their view on it. It would be like if the stuff I entered in Google Sheets or in Microsoft Excel, if Google or Microsoft started saying that they owned it, people would be like, no, you don't. Let's just, make that very clear with the next round of contracting. So no legislation required, just cleaning up the procurement. But in terms of the cost, and of course, I'm just speaking in general, I do think that we need to acknowledge that just as when we're talking about physicians providing patients with a copy of their own data, we're asking these vendors to prepare cuts of data and transfer data that they're not paid for if it's a large organization, or that will have real costs for them. If it's a large organization, maybe that's something they can do. It's part of how they provide a social benefit, but there would be real costs and real work on their part. So I don't think we should expect it to be free. And I actually think the real answer on this is Christine's, and we use the same terminology, collect once, use many times, and actually collect once, process once, and use many times. I think that we're just kind of asking the wrong questions in some ways. I think that maybe the first thing is that as a research community, we need to come together and agree on what it is that we need. And then we can make it clear that absolutely there's no legislative barrier to us having that. And then we can figure out what a reasonable cost is to have that transmitted, to one place or a small number of places and then shared. Because if we get a lot of one-off requests, I just don't think it's going to end well at the end of the day. So I see this as achievable. Certainly other jurisdictions have achieved it, but it's maybe not the specific options put out in the poll.
And I'll just chime in here and just go back to the concept of data as a provincial good or a provincial asset. If we agree in the healthcare system that the need for access to data is critical for whatever purpose, whether it's healthcare service delivery, research, or any of the other use cases, what does that mean? Because there are implications of not having a complete data set. And so if this is a provincial level asset of significance, what should be the rules of engagement around that? Interoperability is definitely a fundamental problem and issue that needs to be addressed. And we've already actually put inside our health privacy legislation requirements starting to put requirements around interoperability between vendors so that data can move more easily from one place to another. And so we already view that as a fundamental requirement of the system, regardless of moving to the future state that I was talking about. So if that is kind of step one, what are some of the other rules of engagement? Should data contribution be voluntary? Should it be mandatory? What data is critical to have? I think those are all questions that we do need to answer in the future state in the context of thinking about data as a provincial level asset of significance.
Kareem, any thoughts on that?
Well, I think, it's extremely complex, right? We've got lots of moving parts and a lot of, there's attitudes, there's technology, there's policy, all of those are difficult. And there's of course finances as well. All of them are constraints and enablers. And I think what we have to be able to do is find ways of identifying what are low-hanging fruit, what are important goals for us as a society, what we want to achieve, and then we work together as a society to move that forward. I think, one of the things that I've been playing around with conceptually is this whole idea of what I call a public sphere. And the idea of the public sphere is that it's a multi-stakeholder kind of governance. And whenever I talk about that, people are like, oh, Kareem, you're too pie in the sky. But the reality is that we do live in a democracy. And, when you live in a democracy, everybody has a veto, especially in healthcare. So whenever things don't work well, people can opt out, just like like we saw in the UK, right? The public did not like the way the organizers ran that care.data and said, hey, stop that. And so if everybody has a veto, it means that everybody has to be at the table to have that discussion. And I think, one of the things that you pointed out is like, hey, the vendors have a role to play, and the vendors have a place here too. And I think, so my sense is, yes, getting consensus and getting agreement across multiple stakeholders is difficult, but that's what we got to do. That is the pathway to sorting all of these things out. Because when each player decides to move forward on its own, based on its own ideas, and saying, no, well, I've consulted with the key players, it's not enough, because the frictions are huge in this space. So I think one of the things we also need to do is understand the frictions to moving forward and be much more sophisticated about how we plan to move projects forward, because we need to have a sophisticated understanding of the frictions. And the understanding of the frictions comes from understanding the stakeholders. Kareem's opinion.
Great. Yeah, that's
Kareem talks about himself in the third person because I put it out there, and it means that you can attack it, and I will have no personal, I won't feel assaulted or defensive because Kareem said it, not me. I'm okay. I'm okay with you attacking it.
So far, I don't think it's something that people could poke too many holes in, because it's a good plan, I think.
Well, it's idealistic,
yeah.
And because it's idealistic, people will agree. But because it's perhaps considered to be unimplementable or too idealistic, people will ignore it. But I hope people won't ignore it, because I think it's only when we have those discussions that we'll be able to move forward.
Great. So I see a couple of questions in the chat, and I definitely want to prioritize those. So the first one I see is, using the UK example, how does the government cover the costs of extraction for the CPRD? Are the vendors paid, or did the government build the infrastructure?
I actually do know the answer to that one. So I'll tell you what the answer is CPRD is actually set up by a non-governmental organization, and they actually do sell the data, and they pay the doctors for that data. So in the UK, that was actually how their EMR infrastructure actually got off the ground. Is they had the EMR vendors subsidized the cost of EMRs by selling the data to the pharmaceutical industry mostly. So yes, that data does get sold, and if researchers want it, they also have to pay for it. Don't ask me how much it costs for the data, but I do know that the doctors actually get paid a substantial amount. It's like, £10,000 a year, something like that.
Right. Yeah. And it's just unclear if the trust was there to really substantiate it going forward, right? So getting to your point about having this, very...
This is going back to the 90s, before all of these controversial issues really arose. The other thing that, is different in the UK compared to Canada is that the UK, in the drug industry, if you're a doctor, you don't need to get permission from the government to test a new drug. Okay, in Canada and the US, we have, new drug applications that you have to apply to the FDA or Health Canada to test a new drug. In the UK, you don't. And in the UK, doctors have there's a whole pharmaceutical doctor training program. Just like we have community health and family medicine and internal medicine, they have a pharmaceutical medicine training program. Okay, and so physicians go into the pharmaceutical industry, but here we don't have anything like that. So there's a much higher level of trust between the medical profession and the pharmaceutical industry in the UK, which we don't have here.
Okay, interesting. All right, I see another question here. I'm wondering if any of the panelists have any reflections on how the pandemic unmasked electronic silos, or want to comment on the strengths and challenges of Covaxon leveraging that for vaccine passports, etc. Maybe Christina, do you have any insight on this one?
So just generally, the pandemic did shine a huge spotlight on the data challenges we have in the healthcare system right now, and just showed that we sometimes do have a lot of restrictions and limitations on how we do things right now. That was really a big catalyst for the work that I described as well, is that we need to make it much easier to support those beneficial uses of data. So I would say that right now, with a lot of the vaccine data, it does require a lot of work and contortions for us to figure out how we can enable and support the use of that data for public good. Not impossible, but very, very difficult right now.
Alison, any thoughts on the ICS side, or?
Yeah, I mean, how can I open with one of the good things of the pandemic, right? What a terrible way to start a sentence. It's increased data literacy, it's increased appetite for data. It's made the case, you think about things like hotspots and bringing more vaccines to them, like using data near real time. So it's done a lot of good in that area. And then I think it just lies with us, as Christine says, for me, it's not about individual consent. I know there's a little bit of chat there. I think sometimes it's absolutely got to be individual consent. I think you want a continuum of things. And I like the language Christina uses, which is the idea of use cases. We don't want to ask people each and every time data are used for any purpose. But at the same time, if they feel like generally it would be used for quality improvement, we shouldn't then say, oh, but we decided to use it in, like AI app development because it might be related to quality improvement. So I think that we've got an opportunity coming out of this to continue and expand uses of data. But we gotta recognize the risks too. And Kareem, I hear what you're saying about CPRD, but for years we pointed to I think it was Denmark and what they did with their EMR data and then they stepped outside of social license and it came crashing down, and you wouldn't think that it could have, but it did. So we just always have to be alert and adapt and recognize that what people are comfortable with will change not just on our own actions, but what they hear about with other organizations as well.
Right. And I think what we need are new social mechanisms in order to manage that. So one of the ideas I proposed in a paper that I wrote a couple of years ago, I did post it here, is that, we can have something called data trusts, okay? And so instead of having your own personal privacy thing, which means that you still have to maintain it. Like the world keeps changing on you. Like you can't say, oh, I've got my personal privacy thing and then I can keep it static. But basically my idea was that let's have these data trusts, and you can have, a continuum of data trusts, from all the way from being fully, we don't do anything with it. We just hide it in there to, we're only about altruistic things to, hey, you know what? I want to monetize my data and I want money for it. So I only want to give it to people who will pay me for it. Okay. And then what you do is you have all these data trusts and you say, hey, there might be 5 or 6, trusts. And you say, okay, that's the one I like because that's the one that fits the way I look at the world. And then you outsource it, and then there's a governance structure that manages it over time, because the reality is that nothing stays stable. And what you want is a good governance structure in place to be able to handle things that are constantly changing. And then you say, yeah, I know what the philosophy is, and I just subscribe to a philosophy, and the mechanics of managing that philosophy are handled by somebody who understands me. And that might be, one approach. And I see that happening in the US. Of course, we haven't seen anything like that here in Canada. But I think we do need some sort of mechanisms that mediate patients' need for control over their own data. And, one of my favorite quotes from a patient about, de-identified data and their ownership over it is, the guy tells me, he says, well, you talk about de-identifying your data. And he says, look, I understand. You think I don't understand, but I understand what de-identified means. But he says, what you're saying is that basically it's like me, borrowing Mr. Jones's car in the middle of the night, driving it around, and then returning it to its original spot and saying, well, you didn't know about it. You didn't need it at that time, and it's back in its original spot. So what's the difference, Mr. Jones? Why are you upset that I used your car? And you're using my data the same way. You say, it's anonymized. You won't know your blood pressure is like every other person's blood pressure, but no, it's still my blood pressure. And even though you took my name off it and you took my phone number off it, it's still mine. And I think, people, about 50% of people actually have that sense of ownership of their data, even if it's de-identified.
I just wanted to chime in really quickly on two points. So the pandemic has also shone a spotlight on the inherent tension that always exists between community and society versus that of the individual. And there isn't necessarily a definitive and clear answer to all situations, all circumstances. I think what is important is having a democratic conversation about how we balance those interests, and that's really important. The second thing I just wanted to point out is that I think that the idea that consent can solve all problems is a myth, because we don't do that in all other parts of our lives. For example, restaurants. We don't need all of our citizens to understand the standards for restaurant hygiene and cleanliness and the temperature at which they need to cook their food and so on. We think that's important that there is oversight on that, but we don't need patients or citizens to consent to that and figure it out and make their own decision about it. And what I would say is that we need to think about what are the right protections and what are the right limits around use of data.
Those are very important points, I think, to end this hour, which flew by. I don't know about you. I think we could talk about this for another couple hours. And but it does sound like, you know, there's some common threads that you're all saying, that the social license, the mechanisms in place that sort of integrate the ability of the patient sort of somehow contributing their preference in a way that reflects their values. You know, it's going to be a journey to get there, as Christina mentioned earlier, but it sounds like we have some good partners, you know, physician leadership, to vendor leadership, and ministry leadership, most of all. So let's see how this plays out over the next few years. So just in terms of the next steps, there will be a post-session evaluation that will be emailed to you, and there'll be a recording of this session as well. Our next session is August 11th, and it's very similar, but probably going to dive deeper into the ethics of all of this, which we touched on certainly. So where does our health data go? Exploring privacy, ethics, and data uses. Dr. Cheryl, moderated by Dr. Cheryl Spitoff. If you have any questions, you can email us at dfcm.excite@utoronto.ca. And we have a web page that describes sort of the work that we're doing as part of Excite, which is this new work on data and AI in family medicine. I want to thank our panelists. This was such a rich discussion. Hopefully we will see some fruits of all of this labor sooner rather than later, because we're eager to be helpful as primary care physicians in this work. Thank you so much for joining us today, everybody.
Thanks. It was a pleasure. Bye-bye.
Thank you.